Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, we do another cardiovascular EMCrit episode. One that is, that should be of interest to everyone. It is on dynamic left ventricular outflow tract obstruction. And you're like, what's that? I don't need to know that. That's rare. That's, nothing I'm ever going to encounter. But no, you're already encountering it. And if you've never heard of it, it's something that's going on in your patients leading to further decompensation. And since you don't know to look for it, you don't see it. But as soon as you understand what this is and start looking, you will find it. And then you will realize that not knowing about it is a big problem. Now, before we jump into that, just some quick announcements. First of all, we just completed Awake and Aware, our conference in Scottsdale, Arizona on joy and flourishing. Holy crap. It was amazing. I will tell you more about it in coming weeks because we're going to do it again. But for now, that is enough to simply say extraordinary. The vertigo course is going wonderfully. That's in my course with Peter Johns on just mastering dizziness and vertigo, such that, you see those in the chart rack or the virtual chart rack, and all of a sudden you're like, ooh, I want that. I want to practice that, rather than, ooh, I hope my partner takes that because I hate those so much. And then the Out on Time course, just a little specification on this. As it stands now, this is a course that will get you out on time, that will make you happier on shift, and will teach you to document, that is made for American emergency physicians. Now, we have plans on expanding that to Australia, to Canada, but for now, you should only buy the course if you are an American emergency physician. More to come on that. So you can find the first one at vertigocourse.com, vertigocourse, all one word.com, and the other one outontimecourse.com. All right, let's get into the show with my partner in all things CV EMCrit and the editor of Cardiovascular EMCrit, Trina, on dynamic left ventricular outflow tract obstruction. So, Trina, you're back again. Another CV EMCrit episode. How have you been?
So good. It's wonderful being back. We're still trying to not freeze here in Rochester, Minnesota. I thought we were going to have a little summer, and then the snow hit us again. So we are back to some ridiculous negative windshield factor again.
Absolutely. You've shared it with most of the rest of the Eastern Seaboard, so you don't have to feel alone. All right.
So true.
But what will warm me is this topic we're going to discuss. So what are we going to be talking about today?
We are going to be talking about dynamic left ventricular outflow tract obstructions. We'll do a general overview, and then we're going to dive into a little bit of nuanced presentations, which is what really got my interest in the last while and why we started talking about this topic.
Absolutely. Now, that is a mouthful. My guess is some of my listeners have no idea what we're talking about. So why don't you start at the most basic, but you want to give some provisos first before we get there. So tell them about the depth of discussion we're going to do on this versus the post, and then just beg them to read that post.
Perfect. I love this. As Scott already referenced here, we are going to be doing a general overview, and our goal is to target this to general emergency medicine as well as the general critical care ICUs. However, the post that I created goes into a ton more detail, especially for those of you who are really interested in cardiac POCUS diagnosis at bedside. Also, for that cardiovascular intensivist, there's actually an entire section at the end of the blog that is targeted to nuanced situations that you will see this physiology. So as Scott mentioned, the post has so much more details than we can go into here. So please definitely read the post if this podcast triggers your attention.
Read it even if it doesn't, because if you're not interested in it yet, you will be after reading the post, because it's far more prevalent than you may think, than even I thought. And you put some literature in there that I don't want to bury the lead. So let's get right into it, and we'll get there when we get there. Okay, what is dynamic LVOTO?
Perfect. So basically, we are talking to an obstruction to blood flow coming out of the left ventricle. Now, Scott, you and I talked about aortic stenosis. I think maybe one of our first episodes that I came on. There, we talked about a fixed obstruction to blood flow from the LV at the level of the aortic valve. Today, we're talking about a dynamic obstruction at the level of the left ventricular outflow tract. So basically, what happens is you classically have this small left ventricle that's hypertrophied. Oftentimes, the septum is thick, and maybe it's sigmoid shaped, and you have narrowing of that left ventricular outflow tract. And what happens is you have this high velocity flow that goes to try to escape the LV, and it actually pushes and pulls that anterior mitral valve leaflet over into the left ventricular outflow tract, and sometimes even causing that leaflet to actually touch the septum, obstructing blood flow out of the left ventricle. At the same time, as you can imagine, if that anterior mitral valve leaflet is pulled against the septum, it's no longer touching that posterior mitral valve leaflet. And now you can actually allow blood to leak back into the left atrium during systole, leading to mitral regurgitation, sudden increase in left atrial pressure, and pulmonary edema. And these patients present for you suddenly that are hypotensive, they're in shock, they're tachycardic, and you're trying to decide why they're suddenly getting worse as you go up on inopressors and inotropes. And when you put your ultrasound on, if you do, you see this really hyperdynamic ventricle. So that's the classic patient that we're talking about today.
All right, I love this. Now, when will we see this commonly?
So you're going to actually see this all the time. In fact, I just saw it this weekend in the emergency department. So not just as an intensivist, and especially not just as a cardiovascular intensivist. So before I jump into the actual scenarios, let's just briefly touch on who's at risk for this. So I talk about structural setup. So classically, most of you guys are going to be thinking about hypertrophic cardiomyopathies. That's only 1 in 500 patients as an incidence. So that's going to be by far the minority of the patients you'll see this in. But the patients that you will see all the time are those patients with long-standing chronic hypertension that end up with significant LV hypertrophy to push against that afterload that they're seeing. So you have these patients that are higher risk that have LV hypertrophy. They may also have a really small left ventricle, and maybe they have some abnormality in their mitral valve. Maybe it's just redundant leaflets that are long that are letting the mitral valve leaflets come closer to the septum, but for some reason they have narrowing of that LVOT. So those are the patients that have a structural setup. But then if you add a physiological trigger, some reason they have a decreased preload, decreased afterload, or an increased contractility, these are the classic patients we're going to see it in. So what scenarios are you going to see this in? As so many things in medicine, it's sepsis, sepsis, sepsis. So there's multiple scenarios, but sepsis is a classic one. Imagine that patient that has chronic hypertension that comes in, and now they come into you septic. So what's going on? First, if you look at their diastolic blood pressure when you put your A line in, if you put one in, you're probably going to see a diastolic blood pressure in the 30s to 40s. They have significantly decreased afterload. So suddenly this ventricle can really empty out and it ends up being really small. On top of that, they are probably febrile. They have an increased catecholaminergic state, their own endogenous, but maybe you're also giving them exogenous catecholamines on top of that. And then, since they have a SIRSI response and they have increased venous capacitance with decreased stress volume, you're going to end up with decreased blood volume coming back to the heart. So that's going to decrease your LV preload. And if you throw in on top of that, they haven't been feeling well, so they're not eating and drinking and they've been vomiting, you might really have intravascular volume depletion. So that is the perfect setup where you will see these patients coming in. Now that's sepsis, but you can also see this in hypovolemic or hemorrhagic shock. More rare things that you might see it in is your septic cardiomyopathy that ends up with a Takotsubo stress cardiomyopathy, or even if they have a large anterior MI, because what these things can do is they can end up with an apical hypokinesis or decreased movement of the apex, but the base contracts really well, which can lead to narrowing of that LVOT and cause an increased obstruction.
You had put a paper in there that said the incidence in septic patients may be as high as 1 out of every 5 patients. So this is not a rare thing. That's why I think this is such an important episode, is you need to be looking for this and you will find it.
And especially, Scott, in this current era where we are vasopressor first, fluid restrictive, I think we're going to see this pathophysiology even more and more. Now, if we're following the spirit of Andromeda Shock 2, where we're doing personalized resuscitation and putting an ultrasound probe on them early, we should be able to pick this up. But I really want listeners to be thinking about this as they're moving towards vasopressors earlier. If you happen to have one of these patients, this might be the patient that you will see a dynamic LVOT obstruction more readily on.
Absolutely. So we have an understanding now of the pathophysiology and who we're going to see it in. But let's say we suspect it. Let's say we didn't. How are we screening for this? How are we recognizing this in the emergency department? Because I don't think there's a way to do it just by clinical exam of the patient. We actually have to grab a probe and stick it in our hand. So tell us a little bit from the perspective of a general intensivist or a resus doc, Trina, on how we could search for this and screen for it.
Absolutely. Now, for people who know me, they know that I love complex ultrasound stuff. So I love continuous wave and pulse wave Doppler. But the thing is that I really want to impress on the listeners is that you actually don't need to do that to get a good idea of what's going on in these patients. So even if you consider yourself having basic ultrasound skills, this is something that you can pick up on. So the first thing that I do is I just put the probe on the patient's chest. Just get the standard views that you're used to looking at, whether that's peristernal long, peristernal short axis, an apical four-chamber view. And what you're looking for is, do I have a hyperdynamic LV? And you know what? As ER docs and general ICU docs, we're good at saying normal function, mildly decreased, moderately decreased, severely decreased. Now I want you to add that additional category, hyperdynamic and even severely hyperdynamic. So that's what you're looking at. If you throw this probe on and you have a patient in front of you that's in shock and really not doing well, and they have a really hyperdynamic LV that looks thick to you in a small chamber, you should instantly be suspecting this. And that's just by using regular 2D techniques. Now, if you want to take it a step further, you can put color on. And really, that's not hard. You're just literally pushing that color button. And if you're on that apical kind of four-chamber swing, so you just get your five-chamber look, you can put color on that outflow tract. And if you suddenly see this alias thing, so this kind of bright array of colors, that can give you an idea that you have high velocity flow. And why is that important? Because remember, for example, if you crimp a garden hose, think about that. You're suddenly going to have really fast flow going through there. So the same way, if you have an obstruction of flow coming out of that left ventricular outflow tract, you're going to have high velocity flow. So by seeing that kind of array of colors that is above the Nyquist limits, above what the ultrasound recognizes one direction of flow, you can have an idea that something might be going on. At the same time, you can put color over the mitral valve if you want to get fancy. And look, do I have mitral regurgitation? But those quick moves can give you a great idea without even doing any more advanced ultrasound things. Now, Scott, I don't know, but I'm old now, apparently. When I was first taught as an EM resident, we used to check the EPSS to get an idea of what our LVEF is. So basically, you threw M mode over that. If we took a peristernal long axis view and we threw it through the mitral valve, and we looked to see how close that anterior leaflet was coming to hitting the septum during actual diastole. If you're used to doing that, then the next thing you could do is just throw M mode once again through that anterior mitral valve leaflet and actually look for what we call SAM, or systolic anterior mitral motion of that mitral valve. And this time you'll be looking for it actually during systole and seeing, is that leaflet actually coming out and hitting the septum or close to hitting the septum? And with those things, you really can just diagnose it right there without even grabbing your Doppler. Although for those of you who are interested, here again, plug, go to the post, because I'm going to talk all about your dagger waveforms, gradients, how to grade it, all of these things.
Okay, so much good stuff in there. I actually think the M mode through the mitral valve is the gateway to people who may not be super skilled, but they should have that capability. This is well within the skill set of every intensivist and ED doc, and you'll see it. Now, I have seen, and Trina, you can maybe tell me how often this happens. I've seen, just by looking at it qualitatively, looking at the echo, oh, that mitral valve's not supposed to be doing that. It's not supposed to be going there over the outflow tract. How often is it that bad that you could actually just see it with your naked eye without the M mode?
Yeah, that's not uncommon. I definitely think once you train your eye to look for that, you can. The one reason that can get challenging is these patients are often pretty tachycardic. So it's just quick movement. So as long as you train your eye, you can definitely pick up on that. And what I recommend is, if you are doing M mode and seeing it's happening, take the M mode off then, start training your eye to pick up on that, so that when you're just doing 2D, you're picking up on it really quickly.
One of the failings of, at least in the ED, my guess is it's the same in most ICUs, is they're doing their echoes without EKG leads. And I was just having this conversation with another guest on the podcast, and it just is so valuable to know what part of the cycle they're in. And I think most ED ultrasounds don't even have leads. Like, they've been lost. They came in the package. Someone just threw them in a drawer somewhere. And that could certainly help, especially on the M mode, to know exactly what you're looking at. When you go down to your emergency department, Trina, are there EKG leads attached to the ultrasound machine?
Sadly, there are not. Now, in the ICU, I do have that capability, and I probably would in the ED, but I'm going to fully confess that I have never used it in the ED. I feel like down there, I'm busily running from one resuscitation to the next. And so trying to find those and spending that extra minute, unfortunately, typically doesn't happen for me. And I'm guessing that's for many of the listeners as well.
Absolutely. All right. Now, as you've already recommended, people should go to the post to find all the advanced ultrasound techniques. In fact, maybe this will be the post that'll serve as the entryway to say, I need to learn how to do all this. I'm going to go find someone in my department or someone in cardiology and have them teach me all this, because the post goes through so many things along the lines of advanced echo to really diagnose this. How often, given the easy mode, things you've already recommended, do you think you'd pick up on it using your advanced techniques that you would not see any indication of it on your easy techniques?
It's very rarely that with those easy techniques that I would miss it that I'm catching it with Doppler. Because in fact, what I've often found is that sometimes finding that perfect spot to catch that dagger shaped waveform on some patients can be challenging. And oftentimes it's the aliasing on color wave and also the aliasing on pulse wave Doppler that will clue me into it, even if I don't see the perfect gradient or the perfect morphology. So definitely do not undersell those easier ways of doing it. At the same time, for those of us who are purists, I'll tell you that I probably personally never diagnosed this completely in my brain without doing the Doppler, but that's also because I'm a little bit of a Doppler nerd.
There you go. All right, fantastic. So it gives hope for the rest of us. And you could always, if you start suspecting it, get a formal echo or bring over your buddy, find Trina in your department and say, hey, Trina, could you look at this echo for me? All right. So now let's say we strongly suspected or we've said, yeah, no, that's what's going on here. How do we manage it, Trina?
Oh, I love it. So management on these is so much fun because this is one of those conditions that if you just go right to bedside, in fact, you should, when you diagnose it, this is not something you diagnose and walk away. This is something that you are at bedside trying to fix in the next couple minutes. So the first thing that I do with these patients is I err towards moving towards giving them increased preload. So classically, that's going to be give them a fluid bolus and then put the probe back on. Look, do I see less aliasing? Do I see improvement in the gradient? Simultaneously, while I'm giving fluids, I typically am also pushing up their blood pressure and giving them increased afterload. Now, here's one of the rare scenarios that my pressor choices might differ a little bit compared to what we typically use. So my go-tos in this scenario tend to be more straight up afterload. So that's going to be vasopressin's good, but it's not the easiest titratable drug. And it's also not that strong. So oftentimes it's that plus occasionally phenylephrine. In fact, I just did that this weekend on a patient. This is one of those few times that those phenyl sticks, I actually love them because normally I hate them. But a phenyl stick in this scenario can be really helpful to say, oh, I'm getting the fluids. I just pushed their afterload up and wow, they look so much better. So this might be one of the few times you're doing that. Now, like so many times in medicine, is norepinephrine the wrong drug of choice? Probably not. There are case reports that say that the beta 1 agonism that you can see with norepinephrine could lead to worsening obstruction. I don't classically see that, but it's something to be aware of. So if you're going to have a hard time getting phenylephrine, is norepinephrine the wrong choice? You can probably use it and you'd probably do fine. But my go-tos here tend to be vaso and phenylephrine.
I love
So
it.
fluids and that are my first starts.
All right, let's go and hit that a little bit harder. If you see a small LV, let's pretend you did nothing else. That's not the classic presentation for these patients. Normally, they have just a normal sized LV. If you saw a small LV chamber, would that spark you to just say maybe this patient would benefit from fluids in general?
So it depends. One of the things I didn't mention with the ultrasound is that you also want to know what's your RV doing. Because before I just assume that this patient is intravascular volume depleted, I'm making sure that the LV is not underfilled because of severe RV failure. Because we're going to get to this with nuanced presentations because maybe your LV is underfilled because your RV is failing and completely unable to push fluid forward, or the LV is impaired from filling because the RV is so dilated. But either way, then treatment becomes suddenly different. But yes, if you go back to it and you say, you know, my RV is good, my LV is underfilled, I look like I am volume depleted and I'm in a shock state, then fluids really is a very reasonable way to go. Clearly, you should expect these patients to then be volume responsive and volume tolerant.
All right, so we're increasing their preload. We're increasing chamber size, which is going to make the dynamic LVOTO better. We're increasing afterload, but we're doing it in a way that's not also increasing inotropy and chronotropy, both. Hey, folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. Those will make the dynamic outflow obstruction worse. And so this is the few times you'll hear Trina actually say that she'll use phenylephrine, and I'm right there with her. It's a very infrequent, but maybe this time. If all you have, your department has just gotten rid of phenylephrine and left norepi, which overall would not be a bad thing, it's probably okay, but just it's stylistically not the best simply because there is some beta there. All right, so that's the first round of management. Is there more advanced management that you add to these patients, Trina?
Yeah, so maybe it's just that my past month has been riddled with these patients, but I've had some pretty complicated ones, including some that have built a lactate up to 11. Yes, next step for me. So once I do those two things first, if I'm still needing to add on therapy, I'm thinking of a couple things. One, oftentimes these patients are pretty tachycardic, and this can be maladaptive. So classically, if you have a slower heart rate, they'll have more time to fill and have increased LV preload, which is helpful for them. So that's one of the other reasons that phenyl and vaso sometimes are nice, because it can cause that reflexive bradycardia. But to tie that in, since these patients often benefit from decreased inotropy and decreased chronotropy, like you mentioned, slower heart rates and less contractile state, once in a while, here's where you're going to think about esmolol. Now, I always use this as my second tier because it's pretty terrifying to make a patient that is hypotensive, completely unstable in front of you, and throw esmolol on them or a beta blocker. And frankly, you can get yourself into trouble. I've seen this used on some of these patients that the patient didn't, especially if you didn't fix their preload first and increase their afterload. So for me, this is the second line. And with esmolol, classically, most of us are taught you start with that 0.5 mg per kg bolus and a drip. Practically, when I'm seeing these patients, oftentimes if I do a bolus, it's a much smaller bolus. I'm doing more of a 10 to 15 milligram bolus. So it might be more of that 0.25 mg per kg, and then starting esmolol more at 50 micrograms per kg per minute. So like much small, just lower doses, and first kind of trialing and saying, are they going to tolerate this? Some people will love it. You slow them down, you decrease their hypercontractile state, and they actually get better in front of your eyes. Others might not love it as much. So this is something that I really am standing right by a bedside. I don't say, hey, go ahead and hang this to the nurse and walk away, because that can be a problem.
Yeah, it makes me yearn for easy accessibility of Landolol, which has even a shorter half-life and really will, if you make a mistake, will cover up your error much more quickly than even esmolol. So
you and me both. In fact, I just asked my pharmacist if we have it, because I'm like, Mayo Clinic, don't we have this? I thought we did. I think they said we do not yet, but I'm hoping that's the yet and that we almost do.
All right. Is there a further tier of management, or is that it for now, Trina?
Those are going to be the big things that you're going to do. If for some reason, and we can get into this for the cardiovascular intensivist, if you have this patient that is in your ICU and you're pacing them, make sure that you are I pacing them, not VVI pacing them. They will not like that. So that's one thing to think about. The other thing to think about is if this patient is an AFib with RVR, these patients hate that. This is probably that patient that's unstable in front of you that you're just going to go ahead and do a synchronized cardioversion. You can always consider some amio, but realizing that if they lose their atrial kick and they're unable to fill that LV, they're going to be really unhappy. So this is the place that you start on these patients.
That's fantastic. All right. We've made it too easy. We just have one ventricle, just normal stuff going around, like your mitral valve, including your ability to get blood out of your heart. Why don't we make it more complicated? Because that's where you're basically the queen, Trina. So let's talk about some more nuanced stuff in LVOTO.
This is probably when it's good that this is not a video that can see my face, because I'm way too excited about this part. So the reason I actually reached out to Scott about this topic is because I kept having these patients that were having dynamic LVOT obstructions because of RV failure. Now, because I am a cardiovascular intensivist, I was classically seeing this post-cardiotomy. So imagine that patient that's classically this older female who's really resilient. She's had aortic stenosis for a long time. Her LV has been like conditioned to it. She has these really thick hypertrophied walls, tiny little chamber. She comes in, she gets her aortic valve replacement. And they decide to do a root enlargement. They put a big valve in, and suddenly she has no afterload. She's really predisposed to this. But on top of that, as they come off a bypass, they catch air in the RCA, which seems to happen too frequently. And now she has a terrible RV. So first, she had that structural susceptibility, and now her RV has failed and just completely not filling the LV. And it becomes really complex because, as you and I will talk about in a little bit, management for RV failure and a dynamic LVOT obstruction are completely opposite in almost everything. Not quite, but almost. However, one of my buddies, Philip Rolla, reached out to me and he said, "Hey, I had this really cool case recently." He said, "I had this patient with a PE, massive, or if you want to call high risk PE, that had severe RV failure and actually had a terrible dynamic LVOT obstruction." And it was interesting because we got to talking about this, and more we're talking about how we're seeing these patients with severe RV failure, whether it's from a PE, whether it's post cardiotomy, whether it's that patient with pulmonary hypertension that ended up with RVPA uncoupling. Basically, their RV is failing. Maybe it's your chronic COPD that has pulmonary hypertension end stage at this point. You are going to see this. And it's not just us cardiovascular intensivists. This is going to be emergency medicine doctors. This is going to be general ICU physicians. And we really need to talk about this because management becomes very nuanced and complicated.
All right, let's talk about that. So what the hell do we do on these patients aside from like run away in fear?
Definitely don't run away. Definitely get your fellows, your medical students, get everyone around because these are fantastic patients to really nerd out about some physiology. So first, physiology before we talk about the management. The question becomes, why are we not filling that LV? I just want to remind the listeners, it's a couple reasons. One, it's because oftentimes these patients have ended up with RV dilatation and stretching. At this point, it's maladaptive. Their tricuspid valve leaflets can't touch anymore. They end up with severe TR, decreased forward flow. So the LV takes one hit there from decreased transpulmonary flow and preload. It takes a second hit when that RV really dilates out, because if you think about it, that pericardium is a set space. And when that RV gets bigger, the LV has less space. So that septum suddenly pushes into the left ventricle and there's impaired LV filling. And if it gets bad enough, it can actually push and compress that LVOT and even further narrow it. So we end up with kind of multiple hits. Classically, it's going to be your patient that is structurally set up for a dynamic LVOT obstruction. And now this decreased LV preload is because of their RV failure. So just to kind of remind them, now we can jump into management if we're good.
Absolutely. Though I'm already scared because everything I want to do on a crashing PE patient is going to just make this worse. So help me, give me a path through. What do I do, Trina? Hey folks, this is Future Weingart. After we recorded this, Trina emailed me and she said, "Scott, I want to make even more sure that people understand that what we're about to say only applies to RV failure and massive PE when the patient has a dynamic left ventricular outflow tract obstruction. So do not do this on patients with pulmonary hypertension, with RV failure, or massive PE when they don't have a DLVOTO. All right? So message sent. You get it now.
Yeah, so these patients are tough. And just to quickly remind you how the treatment is different. So if you think about it, on a dynamic LVOT obstruction, what do we want to do with preload? We typically want to increase it. With severe RV failure, especially, let's use PE as our example size. With we definitely do not want to give a lot of fluid to a patient with a high risk or massive PE. Okay, so fluids are different. What do we want to do from a contractility perspective? With a dynamic LVOT obstruction, we typically want to decrease it, versus with severe RV failure, you really want to increase your contractility. What about heart rate? For a dynamic LVOT obstruction, we want it to be slower. Typically with RV failure, they actually benefit from a faster heart rate. Now, the good news is one thing that they do agree on is they both like higher blood pressures. And that's where I start on these patients. So with both of these, I'm going to try to push that blood pressure up. So here, vasopressin, once again, is a good choice for both of them. It's going to increase your systemic vascular resistance while not increasing your pulmonary vascular resistance or your RV afterload. But as we mentioned, vaso is great, but when your patient's crashing in front of you, it's rarely that vasopressin is enough, even if you're bolusing vasopressin, and I'm not going to get into that on this podcast. So what do I reach for next? Here, I'm typically not going to reach for phenylephrine though. Because unfortunately, phenylephrine, while it's going to increase your systemic vascular resistance, is significantly going to increase your pulmonary vascular resistance. And we have some data in humans that while it can technically increase that aortic pressure and hopefully the coronary perfusion pressure, these patients actually ended up with lower cardiac output in the setting of their mean pulmonary artery pressures went up, their RV pressures went up, their RV cardiac output really decreased. So phenylephrine, bad for these patients. So it tends to be my next go-to tends to be norepi in these patients. Here, that little bit of beta 1 is actually going to probably help you out from an RV contractility perspective to make your audience feel more comfortable. Here, vaso and norepinephrine, pretty good drug choices. I push that MAP to at least 70, and it's going to depend on the patient in front of you as to exactly what they need.
All right, that one seems like an easy one. That's low-hanging fruit right there. What next?
Yeah, it's true. I picked the easiest thing first. I will tell you, the way I'm bringing these up, this is actually the order that I attack these when the patient's in front of me as well. So the second thing I'm doing is trying to decrease the RV's afterload. So the big thing I want to do is make sure that this patient is not hypoxic, hypercarbic, or acidotic, because we know that's going to increase your pulmonary vascular resistance, optimizing all of these things. Now, in my ED or ICU, probably what I'm going to end up doing is putting that patient on high flow and running inhaled nitric oxide on them. I realize that might be more well resourced than some of our listeners are. But what I want you to know is that you can do these things in your ED too. Maybe you don't have inhaled nitric oxide or epoprostenol, but you can literally get your nebulizer out, dump nitroglycerin in that, and it's going to break down to nitric oxide, and you can have them breathe that, optimize their oxygenation, and also have some pulmonary vasodilation there. So you can definitely do these in your ED. So first, I perfuse the RV, and then I decrease the RV's afterload. Next, I think about my preload. So this is where I'm going to use the ultrasound to help guide me. If I put that probe on this patient and their RV is huge, their RV to LV ratio is greater than 1, this RV is massively dilated, I'm realizing that this RV is operating off of its Frank-Starling curve. So once I've optimized this patient's blood pressure, I typically do try to diurese them a little bit because I'm hoping that by getting some fluid off and decreasing that RV dilatation, that I can go ahead and optimize forward flow. Now, I'll tell you that if this is the massive PE or high-risk PE in front of you, you're probably not going to be keeping them in the ED to do all of this stuff or you're lysing them. But if you're sending them to the lab to go ahead for mechanical-based or catheter-based therapies, you probably are not keeping them for that. But these are the things that, if you're continuing to manage them, that I'm thinking through. Next steps after optimizing that preload is if this patient is still doing really poorly, I'm going to start thinking about what do I do from a contractility perspective. So these are patients that occasionally I am pulling out an inopressor because really their dynamic LVOT obstruction is being driven by severe RV failure. So management at this point is targeting treating the RV failure so that it can then fill the LV. So I'm not going to reach for an inodilator like milrinone or dobutamine because that can really get you in trouble. It can decrease your LV's afterload. It's increasing its contractility. That can make that obstruction worse. But what I found is that an inopressor like low-dose epinephrine can sometimes be your friend here. But here again, I may be starting at 0.03 micrograms per kg per minute. If you're someone who does it in, I don't even do this anymore, but I guess
You shouldn't do it. Don't be that person.
Yeah,
Don't
okay,
even tell them.
okay.
You should
I was gonna say
microgram per kilogram for low-dose epi. Absolutely. 0.01 to 0.08. We shouldn't. Don't even give them that space.
All right, thank you. That's making it better because my brain was going to start hurting trying to do some conversions. But this is the type of thing that if I'm starting this, I am staying right at bedside and I am watching how that patient's hemodynamics are being affected. These patients, you should definitely have an arterial line in. You should have your bedside cardiac focus right there and you should be watching. This is not start, walk away, come back type of thing because the patient may love it or they may hate it. You definitely need to be watching that.
Now, I'm sure you would have gotten here anyway, but I just want to steal your joy from you. Wouldn't this be an ideal patient for a protected thrombectomy using VA ECMO? Because we just got too much crap going on with like biventricular failure now. What does it take to make you pull the trigger on these patients? Just say, look, we know they're going to get better after we do the thrombectomy. Let's just put them on ECMO, make it safe, and then we could take them off the day after.
I'm laughing because I paused and I was going to reach for VA ECMO and you beat me to it. So you knew I was going there.
Absolutely.
Yes, absolutely.
The drinking game of EMCrit. Multiple beers will always be consumed when VA ECMO gets mentioned.
It is so true. So I'm laughing because early in my career, if you would have ever told me that I'm going to put a patient on VA ECMO that has a dynamic LVOT obstruction, I would say I'm an epic failure. And if you were putting a patient on VA ECMO just for a dynamic LVOT obstruction, that probably is a failure. But this is the one scenario where you might have to do that. And in fact, it might be the right answer. If you have such severe RV failure that it is driving a dynamic LVOT obstruction and you are unable to medically manage it, absolutely. And in fact, if it is your high risk PE or that massive PE, sounds like this patient needs to be on VA ECMO. We at our institution are pretty aggressive about getting these patients on VA ECMO. Even some of our intermediate high risk PEs that have significant RV strain that we expect them to decompensate during mechanical thrombectomies, we will go ahead and prophylactically put them on, and then we can decannulate right on the table after the procedure.
That's wonderful. All right. Anything more on these nuanced cases, or should we give you a little space, Trina, to talk about the cardiovascular ICU presentations of these patients?
You're a brave man. You're going to actually let me talk about cardiovascular.
We'll give you a bounded domain. You got 5 minutes, Trina. Knock yourself out for that, and then we'll send people to the post for rest.
I love it. I love it. All right. So for the cardiovascular intensivists out there, and also even for others. So just because I say cardiovascular intensivists, I will tell you that more and more people are reaching out to Scott and I saying, hey, look, I've never been trained to work in this unit, but more and more I'm cross covering or I'm working in a unit that actually takes some of these patients. How do I manage them? So definitely go and read the post because I cannot give you a very in-depth view. But the thing I want you to know is that there are a lot of post cardiac surgery patients that are also at risk for this physiology. So I've already mentioned one group. So those patients that have severe aortic stenosis that go in for a surgical aortic valve replacement or even a transcatheter aortic valve replacement. These patients classically have a lot of LV hypertrophy, small chambers, significant diastolic dysfunction. And when you suddenly reduce that afterload by taking care of that fixed obstruction for them, you add on top of that anesthesia, a surgery response from cardiopulmonary bypass that decreases their afterload. They have an increased catecholaminergic state, whether it's because we put on epi or it's just their pain and all of that leading to it. And then they bleed, they're hypovolemic, they have cold diuresis. There's a million reasons, but these patients can classically obstruct, and not just a dynamic LVOT obstruction. They can actually also have an intraventricular obstruction, which I should just briefly mention here. And the reason it's important is not because the therapy is really that different from treating a dynamic LVOT obstruction, but it's just important to know about this so that you don't miss it. Because if you're saying, yeah, they have a hyperdynamic LV and it looks like it's really small and it's really, there's not much chamber size left, but they don't have any systolic anterior motion of their mitral valve, they don't have any MR, so it must not be an obstruction. That's where you can go wrong because these patients can actually basically just completely obliterate their LV cavity and end up with an obstruction. So the important thing is if you are looking that you're putting your color down in that LV and looking for aliasing in the LV, and if you're measuring gradients, measuring it down there as well, because these patients can have intraventricular obstructions that are actually very hemodynamically significant and can cause them to also present hypotensive and in shock. The other populations, though, I want you to think about, though, are the group that's post mitral valve replacement and post mitral valve repair. So these patients can also end up with dynamic LVOT obstructions. In fact, some of the data we have says that as much as 5% of patients after having a mitral valve repair can end up with a dynamic LVOT obstruction. And if you think about it, anything that causes a part of that mitral valve, whether it's long redundant mitral valve leaflets and they can reach over into the LVOT and touch the septum, or if they have abnormal papillary muscles or chordae, or if the surgeon is working with the valve and he makes to the coaptation point where those two leaflets are, is moved closer to the septum, there's multiple reasons these patients can end up with an actual increased risk of dynamic LVOT obstruction and systolic anterior motion of that mitral valve. The other thing that some people who don't work cardiac units aren't as aware of is, especially historically, sometimes when they replaced the mitral valve, they actually left the mitral valve apparatus intact because there was some concern that if they took out the mitral valve leaflets and the chordae papillary muscles, that the LV would end up becoming dilated with decreased systolic function. And so they would leave this anterior mitral valve leaflet and its supporting structures as well as the posterior in place. You can imagine if that's still hanging out in there and they put another valve in there, they're really at risk for having that flap out and actually obstruct the LVOT. Now, with more modern techniques, classically, a lot of surgeons are just plicating or folding that posterior mitral valve leaflet and tucking it in when they put this new valve in. And so they'll leave the posterior they'll leave those chordae and maybe that papillary muscle attachment, but they'll actually get rid of the anterior mitral valve leaflet and the structures. But there is variable techniques as to how surgeons do this. So what I encourage is you should always be reading your op notes and knowing what technique did they use so I know if my patient is at higher risk. Here again, go to the post. There's a lot more details, including specifics and like who I really suspect this in. If you are working with me, the advanced care providers will tell you that I already will predict and stop by in the morning and say, hey, look, you're getting this and this patient. That one's high risk for a dynamic LVOT obstruction. Monitor for it. If they suddenly start decompensating, throw a probe on their chest. And it's because you learn to predict which of these patients may have this. And truly, it makes a huge difference. I will tell you that I walked in just 2 weeks ago into the unit and they were like, you know what, this patient that was doing so well right post-op suddenly has a lactate of 8. We don't understand why. Through a probe on their chest, this patient was doing this. So this is something that if we can actually preemptively expect it, we can really prevent this from happening or treat it right away and really make a difference in the lives of our patient.
I love it. This whole discussion, it brings to mind when you're managing a patient on the ventilator, if you're ever in a situation where their sats keep dropping, you keep adding on more and more PEEP, and they keep getting worse, you think patent foramen ovale, right? And this is of a similar ilk where, you have a patient, their blood pressures are dropping, they're looking like crap, and you're adding on epi, and they're getting worse. Think dynamic LV tract obstruction. All right, Trina, anything you want to leave folks with to sum it all up?
I think the biggest thing is just always keep this in your differential of that sick, crashing patient in front of you. I think, especially in the coming years here, we're going to see this more. And so, if you say, this is something I really don't see in my practice, then I'm guessing you're missing it. Because I'll tell you, even working as an ER doctor this weekend, I saw one patient coming in, and that's not uncommon. I would say I see multiple of these patients a month.
Absolutely. All right, Trina, if you're amenable, I'd like our next episode to be a Q&A episode because we've gotten some questions. We got that question about training for the general intensivist going to a CV critical care unit. We've had some other questions. And so if you're up for it, then I would beseech the listeners to send in all your cardiovascular critical care questions, and maybe we'll make the next episode just a rapid fire Q&A. Well, as rapid fire as CV EMCrit ever is, but I think it'll be a lot of fun. Are you up for that?
I'm up for it. I love it. Let's do this. Go ahead and send these questions. We keep getting so many great questions. And I will say to the listeners, I'm going to work on getting some additional podcasts and posts out there on some of the topics you've sent me. But the Q&A, this will be a great way of covering more of these topics rapidly since I'm struggling to keep up.
Absolutely. All right, Trina, can't thank you enough as always.
It was awesome. Thanks, Scott.